Today we're going to finish up part one of GI, and then we're going to start liver afterwards. Liver shouldn't take very long, so I anticipate that we're going to be completely done with GI today, I hope. So the other day we left off on cholelithiasis. I was showing you what a laparoscopic cholecystectomy looked like. When you're going in there, 3 tiny little incisions, that's all you need. You go in there and just got 2 little tools that help to like cauterize and cut things apart. And you have 1 hole, which is for the scope and the camera. And then once everything is done, you go in there with a little tiny bag and you pull the gallbladder out. And it's a very basic procedure. It's rare when you actually have to go in there and do a big incision, but sometimes it happens. But for the most part, laparoscopic surgery is the way to go. And again, if you were looking at an ultrasound of cholelithiasis, you would see acoustic shadowing. So that's what this image that you see over here is. That's acoustic shadowing, so you can actually see what it looks like on an ultrasound. So we talked about cholelithiasis. Now let's move on into cholecystitis. So this is a little bit different. Now, cholecystitis is where you have effectively infection of the gallbladder. And one of the major causes of infection of the gallbladder is going to be Escherichia coli, E. coli. Of course, it's one of the major bacteria in the GI tract, so it makes sense that if you have an infection of an organ that's very much associated with the GI, that it would be due to E. coli infection. So what do you see with cholecystitis? You're going to see fever, right? Because this is an actual bacterial infection. So you're going to see fever, you'll see leukocytosis or an elevation of white blood cells. You're also going to see pain with this too, right? Cholelithiasis, where you have gallstones, not necessarily going to be painful unless you eat that, huge fatty meal, and then like when the gallbladder starts contracting, that can actually cause a little bit of pain. Generally speaking, the pain is going to be like less than 6 hours, and then it subsides. This one is going to be painful because now you have actual inflammation of the gallbladder. So you're going to get pain, and then it's going to radiate to the back, right? So you're going to actually have referred pain associated with the gallbladder. You could see nausea and vomiting as well, and you're going to see lack of appetite. And especially this is going to take place after you eat a fatty meal, right? Because that's what the gallbladder effectively is responsible for, releasing bile after consuming a lot of lipids. How do you diagnose this? You're going to, again, do an ultrasound to be able to see this. If it's really bad, you might have to do surgery, right? So surgery, cholecystectomy, antibiotics if the infection is really bad. So it gets worse after you eat a fatty meal. And then one thing that you can also do to diagnose this is doing a Murphy's sign. And so how do you do a Murphy's test? So there's 2 types of Murphy's test. There's the Murphy's punch test, and then there's the Murphy's test. The Murphy's punch test is different. That deals with kidneys. So if a person has pyelonephritis, or if they have nephrolithiasis, those are, nephrolithiasis, kidney stones. Pyelonephritis is where you have an infection of the kidneys. You could do a Murphy's punch test, where you put your hand on the patient's back, right at the flanks, and then you gently tap your hand. And if that elicits pain, that's positive. That's a costovertebral angle tenderness, which is associated with kidneys. This is a different Murphy's test. This is the Murphy's test for the gallbladder. I don't know if it's the same Murphy. Might be. Who knows? But this test is going to be a little bit different. Again, you're trying to elicit pain in the patient. So maybe it is the same guy. He just wants to make his patient suffer. So how do you do this? You dig your fingers deep underneath the ribs on the right side, and then you have the patient take a deep breath in. And as they breathe in, their diaphragm contracts, and it pushes the liver and the gallbladder down into your fingers. Okay? So basically what you're trying to do is you're trying to get contact with the gallbladder. And so if that causes a lot of pain in the patient, that's a positive Murphy's test. Okay? So that would be something that would be pathognomonic for cholecystitis. So here are all the pertinent positives. You get nausea and vomiting, right upper quadrant pain, fever, leukocytosis. But the liver is not going to be involved in this. Okay, this is only affecting the gallbladder. If this was choledochal where you're blocking the common bile duct, then you would see liver involvement because you get like congestion of bile back into the liver. For this, you're not going to see any liver involvement. So you're going to see negative AST, ALT. You're not going to see jaundice. If the liver was involved, you might see vitamin K being affected and like elevation in your prothrombin time, but you're not because it's not, you don't see any liver involvement. How do you diagnose this? You can do an ultrasound, and if you see wall thickening or mucosal edema, that's going to be one way that you can see that, you know, the person has cholecystitis. Again, the test that's really important here is going to be your positive Murphy's test. You might see rebound tenderness as well with this. Effectively, when you have rebound tenderness, what does that mean? That means you press down on the patient's belly and it feels okay, but then as soon as you let go, that makes it painful. That's what rebound tenderness means. So if you have rebound tenderness with this, then that would be another sign that this is cholecystitis. You can also do a HIDA scan. That's what the HIDA scan is up here. Basically, it's like a nuclear medicine type of scan, so you can see what's going on with the biliary tree. And again, for this, you want to do surgery, laparoscopic cholecystectomy. And these are all the things that are going to cause exacerbation of cholecystitis. You know, eating a large fatty meal, and then that would start causing contractions of the gallbladder. What's the hormone again that's going to be released that allows for gallbladder contraction? CCK, good. Cholecystokinin, excellent. And then here's another image of an ultrasound. So you actually see some thickening over here of the walls, and then there's your nice little gallstone, the culprit causing all those problems. And here's your HIDA scan. Let me play a little video here that will describe a HIDA scan a little better than I can. So you do intravenous TC99. And it enters into the bloodstream, gets to the heart, gets pumped down throughout the rest of the body. As it enters in through the liver, it's going to go into those hepatic arteries. Then eventually it gets down into the biliary system, so it starts entering into the small intestines. And so with this type of nuclear medicine procedure, you're going to be able to see different regions of the GI tract, including for patients with cholecystitis, you'll be able to actually visualize their biliary tree and gallbladder and all that. All right, so any questions on cholecystitis? Okay, now we're going to talk about ones that are going to affect not just the gallbladder, but can also affect the liver as well. So bile, so here's a side note. Bile is going to be necessary to absorb vitamin K. So it's one of your fat-soluble vitamins. Right, so what are the 4 fat-soluble vitamins? It's ADEC, vitamin A, vitamin D, vitamin E, and vitamin K. Okay, those are the major fat-soluble vitamins. Vitamin K is going to be really important for the clotting cascade, especially factor 7. Okay, so factor 7, that's part of your extrinsic pathway. So remember, when you rupture a vessel, you're exposing tissue factor 3, right? Then that's going to help to activate factor 7. And then eventually you can get the common pathway with factor 10. If you are not able to get bile into the GI and you have choledochal, that's going to affect the extrinsic pathway. So you are going to see elevation of prothrombin. So you're going to see elevation in the PT value. So here's choledochal. So remember, cholo, that means the gallbladder. Docho means the ducts. So this means that now you have a stone that is blocking the common bile duct. And because of that, you're going to see congestion back into the liver, and it's actually going to start causing some issues with the liver. So bile production occurs, right, even though you have blockage. And so you're starting to see congestion. That congestion is what causes the liver damage. So what are you going to see? Nausea, vomiting. You're going to see right upper quadrant pain. It's not infectious, so you're not going to see leukocytosis or fever. But since the liver is involved, you're going to see jaundice and elevation of bilirubin. You're going to see AST and ALT both elevated. We're going to talk about these more when we start getting into liver pathology, so we'll talk more about these different types of tests. You're also going to see reduction in vitamin K, increased PT, and you are going to see clay-colored stool. So we'll talk about that in more detail when we get into liver. So what do you see on an ultrasound? You're going to see dilation of the ducts, and what other tests could you do? You could do an ERCP. ERCP is endoscopic retrograde cholangiopancreatography. So that is a mouthful. So ERCP, that's what we're going to refer to it from here on out. ERCP is a way that you can actually diagnose different issues involving the bile ducts, and it can also help to treat. And I'm going to show you a video on what the treatments look like. I witnessed one of these only once, and it was really cool. So they go in with an endoscope all the way down to the duodenum, then they find the area where you get to the ampulla of Vater, and then they insert a little probe in there. If they find the stone, they can do a little cut. And when I saw it, they did a little cut, and it just like released everything out. It released the stone and a bunch of bile. It was, have you guys ever watched the like Dr. Pimple Popper videos? When I saw it, it looked kind of like that. It's like kind of gross, but satisfying to watch, right? You see like all the stuff just coming right out. It was really neat. This video over here that I'm going to show you is not as dramatic, but it at least demonstrates the concept to you when you see an ERCP. Again, the labs, you're going to see all sorts of liver damage with this. So you're going to see elevations of both AST and ALT, bilirubin, and a reduction in vitamin K. We'll talk about clay-colored stool and get into liver pathologies a little bit later. But let's watch a little video on ERCP right now. So,
endoscopic retrograde cholangiopancreatography is performed using a side-viewing duodenoscope. The scope is passed from the patient's mouth through the esophagus and stomach to the descending portion of the duodenum. A wire-guided sphincterotome is advanced through the scope to the site of the major duodenal papilla. Cannulation of the major papilla is performed with the wire-guided sphincterotome. The position of the guide wire in the bile duct is secured, and the sphincterotome is advanced over the guide wire. The sphincterotome has a cutting wire that is used to cut the biliary sphincter segment using electrocautery. This opens the orifice of the major papilla to allow stone retrieval. A large stone has been identified fluoroscopically. A dilating balloon is used to further open the orifice of the major papilla to facilitate retrieval. The stone retrieval balloon is shown here in the lumen of the duodenum. The deflated balloon is advanced into the bile duct and positioned above the most distal stone. The balloon is then inflated and used to sweep the stone out of the duct. The retrieved stone is shown in the lumen of the duodenum.
All right, cool. So that is ERCP in a nutshell. So you can both diagnose a condition with that. That's involving like the gallbladder as well as the bile duct, and you can also treat the issue that is underlying as well. So that's ERCP, and that's for cholelithiasis. Now, cholangitis is going to be the worst of all these. With cholangitis, that means you have an infection that's basically affecting the entire biliary tree. And it's going to be secondary to cholelithiasis. So now you have a bacterial infection. Again, likely culprit is going to be E. coli. Charcot's triad, you should know this, so highlight that. So Charcot's triad is you get right upper quadrant pain, you get jaundice, and you're going to get fever, right? Because this is a bacterial infection. You're also going to see nausea and vomiting. It's going to be affecting the liver, so you're going to see clay-colored stools as well. And then if it progresses on to Raynaud's pentad, this is where the person can really get into some serious issues, right? You're getting into hypotension, you're getting altered mental status. So that's like kind of like right before the patient could potentially die from cholangitis. You could also potentially see hepatomegaly with this too. So these are all the positive pertinents, right? You got nausea and vomiting, right upper quadrant pain, fever, leukocytosis, jaundice because of bilirubin, AST, ALT elevations. Your PT is going to be elevated, clay-colored stool. However, there's no Murphy sign. You're only going to see a positive Murphy sign when it comes to cholecystitis, when the actual gallbladder itself is infected and inflamed. That's when you actually see a positive Murphy sign. So not with patients with cholangitis. What do you do for diagnostics? You can do an ultrasound. Again, you're going to see an inflamed bile duct. And you could do ERCP on these patients as well. So you do treatment, ERCP, and because it's involving a bacterial infection, you want to give the person antibiotics so you can treat the underlying infection. So that is cholangitis in a nutshell. So ERCP, that's your test and diagnostic and treatment. And yeah, we already saw a video on that, so let me move on. Any questions on the gallbladder for now, before we move on to pancreatitis? I should have moved that whole chart earlier up. I'm actually going to do that on my end so I can remember. Let's go ahead and do that chart right now, actually, and then we'll do pancreas afterwards, since this is nice and fresh in our minds here. So I want you guys to team up, meet up with your best friend in class. I'm going to give you like 5 minutes to fill out this chart, and then we're going to go over it all together. So I'll give you about 5 minutes or so to team up with your best friend in class. I don't want you working on this alone, okay? Work in at least groups of 2, if not more. So go ahead, meet up with your friends. All right, let's start getting into some of these then. Cool. So let's start with the top. So we're going to start with cholelithiasis. What does that mean? What is that? It's a gallstone. Good, exactly. So it's a stone within the gallbladder. Are you going to get nausea and vomiting with cholelithiasis? Yes or no? No, you are not going to get nausea and vomiting. What about right upper quadrant pain? Yes. How long? Yeah, it's usually not that long. It lasts for like less than 6 hours or so. I didn't put it up there, so a little sad face. Fever and leukocytosis? No, it's not infectious, right? You don't have an infection yet. What about jaundice? What about all the liver stuff? None, right? None of the liver stuff is involved. So you have no jaundice. Bilirubin is going to be normal. ALT, AST is going to be normal. Vitamin K is going to be normal. Clay killer stool, not present, right? Is there a positive Murphy sign with this? No, there's not a positive Murphy sign. What would you see on diagnosis? What would you use? Do you want to do an ultrasound? Ultrasound, what are you going to see on ultrasound? Acoustic shadowing, cool. All right, so that's what you see with that. So you'll use ultrasound and you're going to see acoustic shadowing to diagnose cholelithiasis. Now you start getting some inflammation going on, cholecystitis. Is that like an infection? Yeah, that's an infection. You're getting inflammation as well of the gallbladder. So are you going to get nausea and vomiting with this? Yeah, you're going to get nausea and vomiting. What about right upper quadrant pain? Yeah, you're definitely going to get right upper quadrant pain with this. What about fever and leukocytosis? It's an infection, right? So you're going to see fever and leukocytosis. Now, is there liver involvement in this? There is not liver involvement. So none of these values are going to be elevated, right? Including clay-colored stool. Is there going to be a Murphy's sign on this patient? Yes. So this, you get a positive Murphy sign. What are you going to see on diagnosis? You're going to use an ultrasound, right? What are you going to see on ultrasound? Thickening, good. So you get like edema, thickening of the walls. Excellent. Now, choledocholithiasis, where's the stone located? In the common bile duct. Good. So it got lodged in the common bile duct. Nausea and vomiting? So yeah. What about right upper quadrant pain? Yeah. Good. Fever and leukocytosis? Is it infectious? No, you're not going to get that. Now, however, you're blocking the common bile duct. What's going to happen to the liver? You're going to start getting congestion, right? It's going to start building up in the liver. So you're going to see all this stuff. You're going to see jaundice, increased bilirubin. You're going to see increased ALT, AST. You're going to see reduction in vitamin K and an increased PT. Clay-colored stool is going to be present. What about a Murphy sign? No Murphy sign, right? The only thing that you'll see a Murphy sign is in cholecystitis, okay? What would you see, what kind of workup do you want to do on this patient, diagnostics? You want to do an ultrasound, right? And then what else do you want to do? ERCP, good. And then on the ultrasound, you're going to see dilation of the bile duct. Now let's move on to the worst one, which is cholangitis. Are you going to see nausea and vomiting with cholangitis? Okay, so with cholangitis, effectively everything is going to be elevated, right? So you're going to get all that stuff. You're going to fever and leukocytosis. It's infectious in nature. You're going to see liver involvement. Basically everything. What about Murphy sign? Murphy sign is going to be negative in this. So you have everything except for a Murphy sign with cholangitis. And then what are you going to see on an ultrasound? You're going to see all those areas in the bile, like the biliary tree is going to be affected, right? And then you can also do a ERCP with this. Okay, you guys can take a photograph of this if you want. Keep it for your records. All right. Now, moving on, let's talk about pancreatitis. So let me go back. Okay. Where's the pancreas at? There we go. So here's the pancreas. Now, the pancreas, it has some major important functions. You have exocrine function and you have endocrine function. What are the endocrine functions of the pancreas? Going back to endocrinology. Insulin, glucagon, also amylin as well. Huh? Somatostatin. I think it's somatostatin. I can't remember off the top of my head. Low yield for this stuff right now. I think you're right, though. What else? Exocrine function. What's the exocrine function? Huh? So digestive enzymes. Okay, so you're going to be secreting things like amylase, lipase, protease. What does amylase do? Yeah, it breaks down carbohydrates. Then protease, proteins, lipase, lipids. Cool. So that's major things that the pancreas does. Now, if the pancreas gets inflamed, that is called pancreatitis. So pancreatitis, you can have both acute and you can have chronic pancreatitis. Acute pancreatitis, it lasts between 7 to 10 days on average. It can last longer. Sometimes it can last less than that too. But when you have chronic pancreatitis, this usually happens when a person has pancreatitis over and over and over and over again. And at some point, they get chronic pancreatitis. And chronic pancreatitis sucks because basically you're wiping out a lot of those digestive enzymes. You're also going to be affecting the ability to produce and secrete insulin. So the person basically develops kind of like a type 1 diabetes, right, with chronic pancreatitis. So it's a pretty scary situation. What is the major cause of pancreatitis? The most common cause is alcohol. So alcoholism, drinking really heavily, is going to cause or increase your risk of pancreatitis. Not everybody is going to get pancreatitis when they drink heavily, but some people are more prone to it. And so alcohol is going to be the main common cause of pancreatitis. Certain drugs can also do it. Infections can also do it. Choledocholithiasis can also do it too, right? So if you're blocking the ampulla of Vater, right? So that's where you have the common bile duct meeting up with the pancreatic duct, right? If you have a stone impinging on that, you're not just going to get liver involvement, you're also going to see the pancreas being inflamed as well. So those are all really important. And those pancreatic enzymes, once they start spilling out of the pancreas, they literally start just digesting the actual pancreas itself. So it's really not a good situation. If it gets bad enough, you can actually start seeing some serious necrosis taking place with the pancreas. Other things that can cause it, trauma, of course, as well as cystic fibrosis. Remember when we talked about respiratory, you got cystic fibrosis, the CFTR gene mutation, where you have chloride channels are all messed up. It affects lots of parts of the body. The respiratory tract, right, you get really thick, viscous mucus, lots of bacterial infections, but then also the pancreas can be involved too, and that can cause pancreatitis as well. What are the signs and symptoms? It is extremely painful. When a person has pancreatitis, they feel like they're dying. It's like 10 out of 10 stabbing pain. It feels like someone's like literally taking a knife and just stabbing them right in the belly. It's really horrible. It can be periumbilical, but mostly it's going to be epigastric. So just a little bit above the umbilicus. And it's going to radiate to the back. Okay, so you get some referred pain as well with pancreatitis. It's inflammatory in nature, so you will see fever with this patient. You're also going to see things like You're going to see also changes in the heart rate, tachycardia, right, because of the pain. You're going to see nausea and vomiting. These patients are going to be puking a lot. They're going to have to go on things like Zofran, aka ondansetron. That's the generic name for that. So it's an antiemetic drug. Tachycardia, hypotension because of the loss of blood volume. They also might start getting hyperglycemia because of glucagon. And you could potentially see jaundice, especially if it's involving choledochal lithiasis. What are the things that you look for on tests? You can do a CBC. You're going to find leukocytosis. Your glucose levels are going to be elevated, so hyperglycemia. But the enzymes, these are the major things that you're going to do to test the severity of the pancreatitis and then also to track the progression. You're going to see elevation of amylase and lipase. Those are going to be the major enzymes. And over time, you want to start seeing those enzymes going down over time, right? Usually docs, once they start seeing those values going down, they stop even doing those tests because they know that's heading in the right direction. You do not want this. Another thing, CT scan. You can also do a CT scan. You don't want this person eating food because they're having nausea and vomiting. And on top of that, if they eat food, it's going to try to stimulate more release of those pancreatic enzymes. You don't want that. So you want that person to be NPO, which is nothing per oral, for a period of time until they're able to tolerate food. Pain meds, like I said, it's extremely painful. So these patients need to go on morphine. Sometimes OxyContin might be also indicated if it's really bad. And then IV fluids because they're losing a lot of fluids through nausea and vomiting. If it's due to a choledochal lithiasis, then you can also do ERCP for these patients as well. These are the major things that can cause pancreatitis. The most important one on this list is going to be right here, ethanol. So ETOH, alcohol is the most common cause. Gallstones can also cause this too. But it can also be idiopathic, could be steroids, could be cancer, autoimmune. So there's lots of things. This one really sucks. Scorpion sting. You get bit by a scorpion, which really sucks. And then all of a sudden you get pancreatitis on top of that. So a really terrible double whammy. Hypertriglyceridemia. A person who has too many triglycerides is also going to be prone to developing pancreatitis. ERCP in and of itself can also cause inflammation of the pancreas. And then here's our list of drugs that might induce pancreatitis. So here's a couple things that you might see. So the acinar cells, those are the ones that produce amylase, lipase, and proteases. Those get affected. Your pancreatic satellite cells can also get damaged and affected as well. And then what does alcohol do? It's going to create protein plugs. You get spasms, acinar cell metabolism, right? It's going to cause a toxic environment causing damage to the pancreas. So all that is stuff that you would see with pancreatitis. So pancreatitis, pretty straightforward stuff. Can a person die from pancreatitis? Absolutely. A person can totally die from pancreatitis. So lots of, you can get secondary infections if the pancreas gets destroyed. And, you can throw all the patient's labs off of balance, and it can be extremely fatal. So that's basically it for gallbladder and pancreas. Do you guys have any questions on that before you switch over into liver? Sweet. Oh, actually, yeah, let's do these quizzes questions. Forgot about that. So it's 10 questions total. So we'll get through those and then we'll switch gears into the liver. All right, so we're going to start, but I'm going to skip the first question because the first question you guys aren't responsible for. That was for the pre-med students, so let me actually go to the next one. All right, so Barrett's esophagus. I'm sure most of you guys got this one correct. So this is GERD. Oh, wait, hold on a second. Let's see here. Let me read it on my end so I can read the whole thing. So you got Mrs. Davis, 35-year-old woman, presents to the Gastroenterology clinic. Chief complaint, recurrent heartburn, regurgitation over the past 6 months. So that's GERD, basically. She describes a burning sensation in the retrosternal area, worsening after meals, especially when lying down. Her symptoms are often relieved by antacids, but she notes occasional nocturnal coughing and hoarseness. That means that the acids are starting to cause irritation on the larynx and pharynx, causing her to cough. On examination, no alarming signs. Abdominal exam is unremarkable. Medical history includes occasional NSAIDs, not that much, right? So this can basically rule out peptic ulcer disease. Right? It's only occasional. She gets it occasionally for headaches. Upper gastrointestinal endoscopy reveals evidence of erosive esophagitis with visible breaks in the mucosa at the gastroesophageal junction. What would the future progression of this patient be of this patient's condition? Looks like most of you said progression to GERD without complications. This is already GERD and it's already complicated, right? She's already got like inflammation and irritation and breakdown of the tissues, right? So this is starting to develop into Barrett's esophagus effectively. So this is beyond just GERD now. This is starting to get close to Barrett's esophagus. And then on top of that, if this is left untreated and continues as is, her risk of developing adenocarcinoma, so esophageal cancer, goes up quite a bit. Is esophageal cancer rare? It's extremely rare, right? So only like 1% of patients with Barrett's esophagus will eventually develop esophageal cancer. So thankfully, super rare, but still a risk, right? It's still something to be concerned about. Are we good on that? I just want to make sure that we're clear on that because most of you all got this one wrong. All right, cool. Let's move on. Okay, looks like most of you guys got this correct, which is awesome. So this patient, she's been 3-month history. No, wait. Yes. 3-month history of recurrent epigastric pain. It's relieved temporarily by eating. Right there, that should be a huge giveaway of what this is. Right? So when it's relieved by eating, that's duodenal ulcer. Right? If it was a gastric ulcer, the pain would be worsened when eating. Right? And the gastric ulcer inside your stomach, once you eat food, now you got food touching up against the ulcer. Then on top of that, you're getting hydrochloric acid from the parietal cells being released. Okay, so all those things are going to make it worse when you eat. Whereas the duodenal ulcer, When the food enters the stomach, the pyloric sphincter really tightens up, so it prevents food from getting into the small intestines. And so for the time being, while the food is still in the stomach getting digested, you have nothing touching the duodenal ulcer. So that's going to provide a temporary relief. It's anywhere between like 1 to 2 hours or so. Okay, let's move on. All right, what's this disease called? Celiac disease, right? So this is celiac disease. Whoa. This is not H. pylori. This is not H. pylori. Okay, let's read through this. All right, Miss Rodriguez. She's 28 years old. She presents to the GI clinic with a history of chronic diarrhea, weight loss, bloating for the past 6 months. She reports symptoms get progressively worse, and it's associated with fatigue and occasional joint pain. On examination, she's malnourished. She's got signs of dermatitis herpetiformis. That's one of the things that you might see associated with celiac. The studies reveal that she has iron deficiency, and they did studies that found that she has transglutaminase antibodies and anti-endomysial antibodies. If you were to biopsy the duodenum, if a person has celiac disease, you're going to see villus atrophy and crypt hyperplasia. Now, my question to you guys, why do y'all think this is H. pylori? So H. pylori is one of the most common causes of gastric ulcers. Okay, so if you have peptic ulcer disease, one of the major causes is Helicobacter pylori, bacterial infection. Right? And the big thing is you get that bacteria. It doesn't like acidic environments, so it secretes a bunch of nitrogenous compounds. And so it creates its own basic environment, and then you start getting compromise of the mucosal layer of the stomach lining. And so you start getting ulcerations. So this villus atrophy and crypt hyperplasia, that is what you would see on biopsy with celiac disease. That's what this patient has. Okay. Chronic diarrhea, weight loss, bloating, you're not going to get that really with peptic ulcer disease. Okay. Are we good on that? Okay, I want to make sure we're good on that, so we'll move on. I think most of you guys got this one correct. I hope. All right, most of you guys got this right, so good. So you got an old guy, 50 years old, presents to the emergency room, severe left lower abdominal pain. Left lower abdominal pain, that is like sigmoid colon area. So right away you should start thinking, oh, this person might have like diverticula issues. He's got fever, he's got pain, fever, change in the bowel habits. So now this is infected, right? So he's got crampy abdominal pain. And on physical examination, he's got tenderness and guarding. Whenever you like are trying to, do like a physical exam on the abdomen and you're palpating the abdomen, and if you start seeing guarding, like they start wincing and they tense up a little bit, that's what guarding is. He's got leukocytosis as well. So increased white blood count. So this is diverticulitis. It's not diverticulosis. That's the underlying cause. He had probably diverticulosis for a while, but now one of those diverticula got infected, and so now that is diverticulitis, not appendicitis and not gastritis. So this is absolutely like classic presentation of irritable bowel syndrome, IBS. Okay, so this lady, she sometimes gets bloating, sometimes she gets constipation, sometimes she gets diarrhea, right? So this is IBS. Do you really need to do much for this patient? Not really, right? You don't really want to intervene, right? This patient's just, dealing with some GI issues. If it was ulcerative colitis or Crohn's, then you'd want to start intervening. All right, so now things are getting worse, right? So this is not IBS, this is inflammatory bowel disease, right? So this one specifically is going to be Crohn's. Crohn's is most likely to affect the lower left quadrant, okay? So he's got, so first of all, he's complaining of bloody diarrhea. Okay, so he's got bloody diarrhea, he's got cramps, he's got urgency, so he's got tenesmus, which is urgency to use the restroom multiple times a day. Physical exam, tenderness, again, left lower quadrant, okay? Digital rectal exam shows that there's actually blood in the stool. Digital rectal exam is where you put a glove on and you go inside to see what's going on there. Then you see the labs. The labs are going to show anemia and inflammatory markers, aka CRP, which is like the lamest test ever. But CRP at least tells you that there's like inflammation going on. What would be seen on colonoscopy? And so location for this one is going to be one of the key things because Crohn's disease usually affects the ileocecal area. That's going to be the most common area. Other places in the GI tract, anywhere from mouth to the exit, will be affected with Crohn's disease. Crohn's disease is where you see what the majority of you guys answered, cobblestoning and skip lesions. Whereas ulcerative colitis is mostly going to be on the left side, okay, left lower quadrant, sigmoid colon, rectum, and it's going to be continuous, right? You're not going to see skip lesions. A skip lesion means that one area is affected, then everything is fine. Then you have another area that's affected, then it goes fine again. That's Crohn's disease. Skip lesions, cobblestoning. Whereas with this is ulcerative colitis. You're going to see ulcerations, inflammatory changes, whatever. That's not important. But pseudopolyps. Pseudopolyps is one of the major things you see with ulcerative colitis. Okay, let's move to the next one. So ulcerative colitis, same thing that last vignette was talking about. If you were to look for biomarkers, it's panca positive, ASCA negative, right? ASCA is going to be something you see with Crohn's disease. So ASCA Crony. I don't know if that helps. One of my students came up with that, and it's, it works. So good. Most of you guys got this correct. So yeah, affecting mostly the rectum and the sigmoid colon. So excellent. Let's move on to the next question. All right, so this is Crohn's. You got a 34-year-old lady. She's coming in with a 2-year history of abdominal pain, diarrhea, fatigue, crampy, right lower quadrant. So that's the ileocecal junction, right? So that's a really common area for Crohn's. She sometimes gets blood in the stool. She has weight loss, et cetera, et cetera. So what are you going to see? You're not going to see pseudopolyps. That's ulcerative colitis, okay? But you will see aphthous ulcers and cobblestoning. Cobblestoning is pathognomonic for Crohn's. Fistula formation, because remember, it's transmural. Every single area of the wall is going to be affected, and you can get fistulas between 2 different chambers, right? It could be between the colon, the bladder, etc. And then skip lesions. Okay, so skip lesions is huge with Crohn's disease. All right, let's do one more, and then we'll move on to liver. So, Crohn's, ASCA Crony, ASCA positive for Crohn's disease, and you're going to see anywhere in the GI tract can be affected by Crohn's, but most commonly in the ileocecal junction, ascending and transverse colon. Cool. So, any questions before we move on to liver? Are we good on that? All right. So let's move on to liver pathologies. Okay, so Prometheus. I'm not super clear on the Greek mythology as much, but I believe what happened was that Prometheus gave mankind the ability to create fire, harvesting like the power of the sun, basically. And the other gods didn't like that, and so they punished Prometheus. And his punishment was being tied to a mountain every single day. A bird would come down, an eagle, and it would just peck at its liver, Prometheus's liver, eat most of his liver, and it would fly off. Over the course of the night, it would regenerate because the liver regenerates. And then the next day, the eagle would come back and keep on eating his liver. And that was his destination or destiny for the remainder of his entire existence, right? So that's Prometheus. And the reason why I bring that up is because the liver can regenerate itself. If you were to do a liver transplant procedure, I was actually just talking to one of my students about this just the other day. If you were to do a liver transplant, you can actually get a live donor, so long as you get your typing done to make sure that you have a good match. It's especially better to have it within the family because that increases the likelihood that you have a better match. So you don't have to necessarily be on such high dose like graft rejection drugs like immunosuppressants. But a person can get 20%, 30% of their liver and donate that to someone who needs to be a recipient of the liver, and it will grow, right? The donor's liver will grow back again, and the person receiving the transplant, that liver will now grow out, right, into its normal size. Now, that's assuming, of course, the person who's receiving the liver transplant, right? A lot of people who get or go into cirrhosis and need a liver transplant, a lot of times it's alcoholism. And if the person is still an alcoholic, like a raging alcoholic, then that transplant's also going to fail, right? Because ultimately they're still going to be drinking, and then they're going to wind up killing the liver that they just received as a donation. So that being said, let's move on and talk about all the different types of liver disorders that you guys are going to be responsible for. So here are some of the major liver disorders. So viral hepatitis, alcoholic hepatitis, fatty liver disease, steatosis, non-alcoholic steatohepatitis, cirrhosis, and Wilson's disease. Oh, here we go. I just went to this slide over here. So yeah, Zeus was the one that decided to punish Prometheus. I should probably review my slides in advance before I start spouting off. So moving on. So liver can regenerate. These are the areas that, some of the areas that are allowing for liver regeneration to take place. And even if you have 10% of your liver left, the liver can still regrow. It's really amazing. The liver is an extremely incredible organ. I was talking to my best friend last night about this, and he jokingly said, it's almost as if God knew that we were going to really need our livers a lot. He likes to drink a lot, so. Even if you have steatohepatitis from alcohol, that can be reversible. It only takes like a few weeks, sometimes a couple months. If you're drinking a lot and you get fatty liver disease, sometimes that can actually go back to normal if you just stop drinking for a period of time. So the liver is actually really incredible. It can regenerate a lot. Now, if the liver does get damaged, what's going on? You're going to get jaundice. So we were talking about that when we were discussing cholelithiasis, right? Where you have backup of bile back into the liver, causing liver damage. You get jaundice, yellowing of the skin. So that's what jaundice is. Basically, it's a sign of liver damage. This image right here, that is sclera icterus. Sclera icterus means yellowing of the sclera, so yellowing of the eyes. What's going on with bilirubin? So when red blood cells get broken down, portions get separated out. So you get heme separated from globulins, and the heme is broken down into biliverdin and iron. Biliverdin is green in color, eventually turns into bilirubin, and bilirubin is the one that's yellow. If you were to get like a bad bruise, right, you get a bad bruise, sometimes you can see actually like the way that the color changes over time as the bruise is healing. You can kind of see it going from kind of dark greenish color, dark purplish color, and then eventually starts turning into a yellowish color, right, before it's starting to heal, right? So that's kind of what's going on with the bruise. It's very similar progression in terms of color change. Then bilirubin is unconjugated, which is fat soluble, until it gets to the liver. In the liver, it becomes conjugated bilirubin, and conjugated bilirubin is what's water soluble and gets sent off into bile. If you have lots of unconjugated bilirubin floating around, that probably means that you have some sort of hemolytic disease. So it could be like a hemolytic anemia. You could get this with sickle cell disease. You can get this with megaloblastic anemia. Whenever you have red blood cells that are starting to burst a lot, malaria as well. Malaria, part of the life cycle of the Plasmodium falciparum, Plasmodium vivax, any of the plasmodiums. Part of their life cycle is to go into the red blood cell, and then they burst out of the red blood cell when they're ready to go off and infect more cells. So you would see an elevation in unconjugated bilirubin. But if you were to have actual damage of the liver, then you would get an elevation of conjugated bilirubin. So you would see that with cirrhosis, hepatitis, and any of those bile duct obstructions, so like cholelithiasis. So what does a normal liver do? So it's going to be responsible for producing your clotting factors. So we talked about this when we talked about the clotting cascade, right? So clotting factors are produced by the liver. Also glycogen storage of other things too, like vitamins and minerals, like vitamin B12, for example. If a person is like a vegan and they're a vegan for a really long time and they're not really doing well in terms of vitamin supplementation, It actually takes a long time for a vegan to eventually develop anemia, right? Megaloblastic anemia. It takes a long time because there's a lot of vitamin B12 stored in the liver. Once you exhaust all those reserves, then you develop the anemia. Also, glycogen is really important as a storage molecule for energy reserves. Albumin production. Albumin is a really important protein that you find in your plasma that helps to maintain oncotic pressures. If you don't have albumin, you're going to get what? Edema, yeah. So you get edema, you get ascites, right? Ascites is where you have fluid accumulation inside the peritoneum. So I'm going to show you what that looks like when you have end-stage liver failure, cirrhosis. You're going to see ascites and some other stuff too, which we'll talk about in more details. What else does the liver do? It breaks down drugs, it metabolizes alcohol, and it can also help to store things like glucose, cholesterol, and triglycerides, etc. Dang it, I did not put this. I need to update the slide. So let me pull up. Let me do something real quick. I'm going to do a little switch just for this one slide, and then I'll switch back again. So I included this in my pre-meds lecture presentation. So let me go into that real quick. And then we'll switch right back over again. Here we go. So, cirrhosis. No, that's not what we're talking about. Gosh, there we go. All right, LFTs, liver function tests. Okay. This is not super high yield. I just put this in here because some of my pre-med students, they like to dig even deeper. What I tell them is not enough. Apparently, they like to what's the reason why you have this? Like, what do these things do? So it wasn't just enough to say that AST and ALT are something that you would see in a liver function test. They wanted to know exactly what those things do. So AST is aspartate transaminase. It's an important amino acid for metabolism. ALT is alanine transaminase. This one helps to convert alanine to pyruvate. That's for energy, metabolism. Then you have bilirubin and albumin, and then you have gamma-glutamyl transpeptidase, or gamma-GT, and that is important as a transport molecule. Now, these are all things that you can use to test in a lab how your liver is functioning, if it's functioning properly, and if it's not functioning properly, you can see what type of disorders might be the underlying cause of those abnormal lab values. So let's start with alcoholic hepatitis first. This is not cirrhosis. This is before you get to cirrhosis. Alcoholic hepatitis. The thing that is elevated the most is going to be AST. AST is going to be really high compared to ALT. ALT is going to be maybe elevated, but not as high. So if you were to do a ratio and you were to divide AST over ALT, then you're going to have an increased ratio. So the ratio is going to be above 2. Okay? You're also going to see gamma-GT elevated in alcoholic hepatitis. You're also going to see bilirubin. Bilirubin is going to be elevated in all of these. It's going to be elevated in alcoholic hepatitis, NASH, viral hepatitis, and liver cirrhosis. Okay, you're going to see elevation in bilirubin. Then with NASH and viral hepatitis, the one that's elevated the most is going to be ALT. So if you put ALT on the denominator on the bottom and AST on the top, right, and you divided it, it's going to be a decimal. So it's going to be less than 1 in terms of its ratio. And then cirrhosis, both of those are going to be elevated. You're going to see elevation of AST and ALT, but they're going to be elevated kind of in a similar way. So it's like maybe AST is around 300, maybe ALT is around, I don't know. I'm not going to give you a number off the top of my head, but long story short, it's going to be above 1, but it's going to be less than 2. Okay, so that'll be the ratio. I'll show you a couple calculations in a second of what that would look like. And you have a reduction in albumin with cirrhosis because the liver is done. It's failed. Now you're not able to produce albumin. You're not able to produce your clotting factors, right? So you're going to see an increase in bleeding time. You're going to see an increase in PT, increase in APTT, and then if the spleen is involved, which we'll talk about a little bit later, if the spleen is involved, you're also potentially going to see an increase in bleeding time, BT. Right, because you might see platelets getting sequestered into the spleen. So we'll talk about that a little bit later. So let me switch back over to your guys' lecture slides. I just put that up there. It's not important for you guys to know what those actually do. I just put that in there just, if you were curious. So here are some examples of how you would calculate those ratios. So if your AST was 100, your ALT was 200, you divide 100 over 200, that's going to be 0.5. That's less than 1. That would be NASH or viral hepatitis. If your AST was really high, 300, and your ALT was only 100, you divide 300 over 100, that's going to be about 3, and it's going to be over 2. Okay, so that's going to be alcoholic hepatitis. If both were elevated, but kind of similar in terms of how, like, their numbers, so AST 500, ALT like 333, you divide it, it's 1.5. It's above 1, but it's going to be less than 2, and so that would be cirrhosis. So these are all things that you would see in terms of your liver function tests. So what's the progression of liver damage? When you have the initial stages of liver damage involves steatosis. Steatosis is basically fatty liver disease. And then eventually, as steatosis progresses even further, now you start getting fibrosis. Fibrosis is reversible. But then once fibrosis goes far enough, now you're getting into the territory of cirrhosis. Cirrhosis is not reversible. That's it. The only thing you can do is hope that you can get a liver transplant. That's all that can happen once you get cirrhosis. So let's watch a couple videos here that talk about these different stages. So steatosis, fatty liver disease. All right, you guys get the idea on steatosis. So that's fatty liver disease. Alcohol and obesity can predispose a person to getting steatosis. Fibrosis, that's the next progression after steatosis. Okay, so once you start developing fibrosis, you start to see more symptoms coming about, especially jaundice, right? Once you start seeing jaundice, that's a scary sign. That means cirrhosis is right around the corner. So cirrhosis is the last stage here. All right, you guys get the idea now. What is one of the biggest concerns? Well, cirrhosis is horrible, right? So lots of stuff is going on with cirrhosis. But one of the biggest concerns once you start developing cirrhosis is an increased risk of this right over here. You guys know what HCC stands for? Take a guess. It's kind of similar to like when we were talking about like Barrett's esophagus. The end stage was esophageal cancer, right? The end stage of cirrhosis is hepatocellular carcinoma. So HCC stands for hepatocellular carcinoma. So that's one of the biggest concerns when you have liver cirrhosis. That can be due to alcoholism. That can be due to viral hepatitis, especially hepatitis B and hepatitis C, which we'll talk about in a little bit. So that's all that's going on there. We'll discuss more details in a little bit when it comes to cirrhosis. Yes? Not necessarily. Sometimes kids can have a little bit of a jaundice when they're born, and sometimes that can like clear on its own over time. So that's not totally uncommon. Usually they just need to be exposed to, I think it's UV light, if I remember correctly, UVA, and so that helps to kind of like clear out the jaundice. But you're talking about like really little kids? Oh. Could be a lot of things that can cause. It could be parasites. It could be malaria, right? And especially in developing nations, like in parts of Africa, there's lots of malaria, and malaria causes jaundice, right? Because it's just you're getting hemolytic anemia. It's destroying the red blood cells. But there's lots of things that can cause sclera icterus and jaundice. So yeah, infections could be one of them. So that's a really good question. Inflammation of the tissue of the liver, that's hepatitis, basically. Hepatitis is anytime you see inflammation of the liver. What can cause this? Viruses. There's lots of different viral hepatitis types. There's hepatitis A, B, hepatitis C, hepatitis D, hepatitis E. So there's lots of different types. Alcohol can also cause hepatitis, obviously. NASH, that is non-alcoholic steatohepatitis. So it's not alcoholic, but it's mostly caused by obesity. So a person being a little bit too heavy, right, having too many like lipids, triglycerides, that can cause fatty deposits within the liver as well. Signs and symptoms, you're going to get fatigue, you can get some flu-like symptoms as well, abdominal pain, nausea, vomiting, jaundice, all that stuff. What do you look for in labs? Bilirubin, ALT, AST, gamma GT. You look at the ratio between those to diagnose exactly what the type of hepatitis you might be dealing with. Okay, so those are all things that might cause hepatitis. Now let's focus on alcohol. So with alcoholic hepatitis, if it's acute, you're going to get mild signs and symptoms. So nausea, vomiting, weight loss, abdominal pain. You could get jaundice as well, hepatomegaly. Hepatomegaly means that the liver is now becoming enlarged. Okay, so that's something that you might see as well. And then the labs, again, AST-ALT ratio is going to be over 2. Okay, so over 2 to 1. So AST is the one that's going to be elevated more so than ALT. You're going to see gamma GT and bilirubin elevated as well. Once you start getting cirrhosis as well, you can get hepatomegaly from that, from the portal hypertension. And if you're looking at a biopsy and looking at a histological cross-section, you would see ballooning and Mallory bodies of those cells that are involved. Don't worry, I'm not going to test you on histology for the exam. So you're not going to have to look at this picture and be like, what the hell are those? I'm not going to make you guys do that. So just know ballooning and enlargement of the cells. You can also get hepatomegaly because of the ballooning. And then Mallory bodies, that's just basically misfolding of proteins, keratin specifically. Steatosis, that's fatty liver changes. And of course, you want to see what their history is. And if they have a history of alcoholism, there you go. That's the reason. That's probably the underlying cause of their hepatitis. Now let's focus on viral hepatitis. I really don't care about hepatitis G. It's super rare, but these are the other ones that are more important. A, B, C, D, E. For hepatitis A and B, all of us in this room, well, at least myself, when you guys go into your clinicals, you're going to get your hepatitis A and B vaccines. I had to get my hepatitis A and B vaccine when I started doing my clinicals as well. So anyone who works in a hospital setting has to get the A and B vaccinations. The ones that are most commonly transmitted by food, that's going to be hepatitis A and E, contaminated food and water. Common backstory to those would be like, oh, I traveled to a developing country that didn't really have good sanitation, right? So that would be one risk factor for contracting hepatitis A. Hepatitis B and C are a little bit different. B is sort of considered a sexually transmitted disease. Sort of. The thing is, though, you can also get hepatitis B from like contaminated needles as well. But, you know, think about hepatitis B as being associated with body fluids. Hepatitis C is a little bit different. Hepatitis C is usually going to involve what this dude is doing over here, IV drug use. Okay, so IV drug use is one of the most common ways to contract hepatitis C. But not just drug users, like old people that have tattoos that they got back in like the 60s and 70s and 80s and stuff. If you went to get a tattoo done back in those days, the tattoo artists weren't that very diligent about cleaning their needles. So it's very common for an older person who has tattoos to have had hepatitis C. But I want you to sort of associate both of those with IV, intravenous contraction, as well as like sexual contraction. Hepatitis C, not sexual, hepatitis B, but they can both sort of be transmitted through needle use as well. Hepatitis D requires co-infection with hepatitis B, either at the same time or if the person previously had hepatitis B and got over it, they can still get hepatitis D. So you have to have a co-infection of some sort with hepatitis B. And the big concern with hepatitis B and C is that they can become chronic. Hepatitis C, if left untreated, virtually always becomes chronic at some point and develops into cirrhosis. Hepatitis B, on 20% of occasions, will turn chronic. 80% just resolve over time, but 20% will become chronic and turn into cirrhosis. And the biggest concern with cirrhosis, again, is HCC, hepatocellular carcinoma. So that's one of the biggest concerns there. Cold and flu-like symptoms, would be one of the symptoms that you would see with hepatitis: abdominal pain, nausea, vomiting, jaundice. Okay. By the way, hepatitis A and E. A, you get like sometimes when you travel, right? So that's one of the concerns. And it's acute, so it's not going to last very long. It lasts like a month, maybe a little bit longer than a month. Hepatitis E looks almost exactly like hepatitis A, except for with hepatitis E, the biggest concern is pregnant mothers. It can be way more severe in pregnant mothers if they get hepatitis E. And then you can do viral testing for this. You can do antigen and antibody testing for different types of hepatitis. That's one thing you can do in the lab. You can see your liver function tests. So AST, ALT, bilirubin, all that stuff is going to be elevated. But if you did the AST to ALT ratio, it's going to be a decimal. So it's going to be less than 1. And these are all, this is a nice little summary, like talking about all the different types of hepatitis and, you know, the signs and symptoms and all of that and how you get it, etc. By the way, hepatitis C nowadays, it's actually kind of interesting. Like back when I was in med school, there was really nothing you could do. And there's certain drugs you could take, like ribavirin is one antiviral, pegylated interferon is another drug you could take. So there's like a handful of drugs you can take. But nowadays, the treatment, it's like really good. It's to the point where you can virtually cure a person from hep C. So that wasn't the case when I went to med school. Nowadays, things have definitely advanced a lot, which is really good. All right, now let's move on to NASH. So this is non-alcoholic steatohepatitis, effectively fatty liver disease. And it's pretty popular, especially in the United States. About 1% to 2% of people will have some form of fatty liver disease. Why? That's because obesity is a major problem within the United States. United States, Western world, Western diet, all that stuff, right? We basically eat too much. The first and only autopsy I was ever involved in when I was in, I think I was in my second or third year of med school. No, second year, transitioning into my third year. It was this lady. She must have been like, God, I would, if I had to guess, probably 400 pounds. And so they like put her onto the table, and then when you do an autopsy, it's pretty gruesome. You cut through the entire sternum using like basically hedge clippers. You like cut right through the sternum and then cut everything open. And then they cut through the trachea and the esophagus. And it was amazing to watch. They grab the trachea and they just pull everything out. And they plop all the organs and everything onto basically a black garbage bag. And then what they do with an autopsy is they cut through all the tissues and they'll do like little tissue samples so they can send it off to lab to see what the cause of death was, toxicology reports, all those types of things. This lady was huge. And when they cut through her liver, just like you could see all like the grease just coming out of the liver. So she had really bad fatty liver disease. And so obesity is going to be the major cause of this. So high cholesterol, high triglycerides, so hypertriglyceridemia, diabetes, things like that. What's going on with NASH? It's silent, right? So you don't really notice it. You'll maybe get dull abdominal pain, and then you could potentially develop jaundice, right? So if it's pretty advanced, then you might start seeing jaundice. And if you were to look at a histological slide, this is a normal liver, looks really nice, and then fatty liver disease, you get all those little lipid accumulation within the cells. So that is NASH. And for testing for NASH, you're going to see elevation of ALT and AST, but it's very similar to viral hepatitis. The ALT value is the one that's going to be higher, right? So if you do the ratio, again, it's going to be a decimal point, so it's going to be less than 1. Bilirubin, of course, is going to be elevated. Like I said before, bilirubin is elevated in all of these liver disorders. And you can actually see this in ultrasound. If you were to do an ultrasound on a patient, you could see the fatty changes within the liver. And you could do a biopsy if you wanted to determine whether or not the person had like cirrhosis or anything like that. This is like totally FYI, but foie gras, I think I pronounced that correctly. Or is it foie gras? French? I don't know. So that's fatty duck goose liver. And so what they do is they just like feed this duck like crazy. They feed the duck so much food to the point where like the duck can't even really move very well. And yeah, so you're force feeding the duck basically. And so if you were to eat the liver of one of these fattened geese or ducks, it's one of the most cholesterol-rich foods out there. So pretty wild stuff. Has anybody ever had foie gras in here? Was it good? It's okay. Oh yeah. Well, how do you eat it? Is it like a pate? Do you put it on a cracker? You put it on bread? Oh, sounds kind of good. Sounds or a little baguette. All right. Sounds kind of nice. I've never had it before. No. Yeah? I'll try it sometime. However, I got my labs the other, like over Thanksgiving break. My LDLs were 1 point above what they should have been. I was like, what's going on, man? Getting old, I guess. Getting old, now my cholesterol's going up. It sucks. So maybe I shouldn't have foie gras. Anyways, cirrhosis. Now this is end-stage liver disease, right? So you have cirrhosis, so fibrosis, and then cirrhosis. So end-stage liver disease. These are all the different causes, the things that we already talked about. The liver, if you were to actually look at the liver, it's going to be kind of like yellowish, greenish, brownish. And the size, it depends on what the underlying cause is. If it's viral, the size might not change much. Alcoholic hepatitis, however, you will get hepatomegaly, so the liver does get larger in its size. Histology, this word right here, parenchyma or parenchyma, that is the functional units of an organ. So if you talk about the destruction of the liver parenchyma, that's like the parts of the liver that actually are supposed to do stuff, right? And if you lose the function of those tissues, that's when the tissue doesn't work anymore. And then you would see fibrotic nodules, fibrotic tissues, and all of that. Now, labs, PT and PTT are going to be elevated. Why is that? Clotting factors. So PT, that's extrinsic pathway. PTT is intrinsic pathway. So a lot of the clotting factors that are required for the clotting cascade are going to be affected if the liver is damaged. Again, albumin produced by the liver, it's going to be reduced. Again, bilirubin elevated, just like all the other ones. AST, ALT, gamma GT, they're all going to be up. And then the ratio, again, of AST and ALT, above 1 but less than 2. So what happens when the liver becomes cirrhotic? Basically, you have this nice little pickled liver. It's lots of fibrous tissues. It's stiff. The blood vessels are also not going to really work very well. And so you start developing a condition called portal hypertension. And when you have portal hypertension, the blood is going to have to move somewhere. So it's going to find alternative ways to move. So it's going to start shunting into different regions. So one common area that you would see it getting shunted to is up the esophagus. And so if you have esophageal involvement, we have blood now shunting over to the esophagus, you're going to start seeing dilation of those esophageal veins. And that's called esophageal varices. And those esophageal varices are highly prone to rupture. One of my favorite authors, raging alcoholic, hilarious writer, this is how he died. He started getting these uncontrollable bleeding esophageal varices, and that's what ultimately led to his demise. His name, Edward Abbey. He's actually from around here. Some of my professors at ASU actually knew him personally. So he used to come to ASU all the time to like do lectures. He wrote a couple really groundbreaking books about like the desert, Arizona. Desert Solitaire was one. Monkey Wrench Gang was another. He was also a very wild dude. He had an FBI file because he would go out in the desert and burn shit down, and they called him the desert anarchist. And he's just a really interesting character. He's the guy that actually helped found, I think it was Earth First, one of those like environmental organizations or something. So he's a pretty interesting dude. But like I said, raging alcoholic. He talks about it a lot, even in his own stories. Stealing cop cars, drinking beers while driving, throwing them out the window and stuff. Just a wild dude. But anyways, this is how he died. And then when he died, to wrap that story up, he had his friends. He didn't want to be like in the hospital, and he didn't want to be buried normal. So his friends like stole his dead body from the hospital. They threw his body into the back of their pickup truck, drove him out in the middle of the desert in Utah, and just like buried him in the middle of the desert. And like I think only a few people actually know where he's buried. So He's a hilarious guy. One of my favorites. Esophageal varices. That's going to be one of the major things you see. What else do you see with portal hypertension? There's a condition called caput medusa. Caput medusa. Medusa, like the mythical figure, right? It's got all the crazy hair. So it kind of looks like that, but it's on the belly. So you get all these blood vessels just kind of like everywhere around of the belly. So that's like the way that the blood is going to be shunted. You can also see splenic involvement too. If you see splenomegaly being involved in this, the spleen can tend to start sequestering platelets from the blood. So you can get thrombocytopenia when you get splenomegaly. And what kind of value would you see elevate if you have thrombocytopenia? It's a platelet type bleed, right? You get platelet bleeding disorder. So what? BT, yes, bleeding time would be elevated. So if you have splenic involvement, you could potentially see elevation in your bleeding time as well. Let's see a little video on esophageal varices here. So when you hear the term ligation, that's what's going on over here. So it's endoscopic variceal ligation. Ligation means to reconnect blood vessels. So if the blood vessel's ruptured, you can try to reconnect those blood vessels to prevent the bleed. All right. So that's one potential procedure that you could do as well. What's this one over here?
Patients with portal hypertension may be asymptomatic or present with symptoms due to variceal bleeding, ascites, encephalopathy, or hypersplenism. Variceal hemorrhage can occur most commonly at the gastroesophageal junction and result in death. The TIPS procedure creates an artificial conduit from the portal to the systemic venous circulation to resolve portal hypertension and recurrent gastroesophageal varices. A small incision is made in the neck to access the internal jugular vein. A guide wire, followed by a sheath, is advanced into the internal jugular vein, ending in the right hepatic vein. A catheter is advanced over the wire into the hepatic vein. After the wire is removed, indirect pressure is measured using a balloon at the tip of the catheter. Once the catheter is removed, a long curved needle is placed through the sheath and thrust through the wall of the hepatic vein and adjacent parenchyma into a major branch of the portal vein. A portal venogram is performed via the needle to confirm proper placement. A wire is advanced through the needle. After the needle is removed, a pigtail catheter is advanced over the wire. The wire is removed. Direct pressure is measured in the portal vein to check for a significant gradient. The wire is placed back into the portal vein and the pigtail catheter is removed. A balloon catheter is used to dilate the tract between the hepatic and portal veins. The balloon catheter is removed and the sheath is advanced over the guide wire. The stent is advanced through the sheath until it is in proper position, at least 2 centimeters into the portal vein. The sheath is removed and the distal 2 centimeters of the stent in the portal vein expands. The ripcord is pulled slowly to open the stent. Portal vein pressure is checked to make sure it is lowered. Everything except the stent is removed. This stent routes the portal flow directly into the hepatic vein, bypassing the liver.
So that's a really, really cool procedure. By the way, something I want you to scratch off of your slides because I didn't include this correction here. So hemoptysis, what's hemoptysis stand for? Huh? Coughing blood. So that's why I wanted to remove that from here. It's not hemoptysis, it's hematomesis. So hematemesis. Some people call it hematemesis, but I say hematomesis. Hematomesis means you're puking blood, you're throwing up blood. So if you get a ruptured esophageal varices, then you're going to start vomiting a lot of blood. Okay. So I apologize for that mistake there. So cirrhosis, you get obstruction of the blood flow, and you get like basically shunting of blood to different areas. So here's an example of those esophageal varices. This is what ascites looks like. This guy's belly is massive. And then caput medusa, all those little blood vessels throughout the abdomen, grossly enlarged, right? Grossly dilated. So super scary situation, very unsightly, unfortunately, for those patients. So here's a nice overview of cirrhosis. You get reduction in albumin, then you're going to get ascites. If you have difficulties in producing your clotting factors, you're going to get PT and APTT elevated, increased risk of bleeding, as well as if you get the spleen involved, then you get thrombocytopenia and increased bleeding time. You can also get hepatic encephalopathy. Ammonia can start building up in the blood, and that can actually start affecting the mind. You can start getting asterixis, which is kind of like a hand flapping type tremor, kind of looks like that. You're flapping the hands. So you have the patient like hold their hands out like so, and they start like flapping their hand. That's asterixis. Jaundice, of course, with bilirubin. And then you get increased estrogens as well. And for guys, if you have too much estrogen, you start developing breasts, and that's gynecomastia. Okay, so that's what you get with increased estrogen. Signs and symptoms, edema, jaundice, fatigue, all that stuff. Portal hypertension, ascites, esophageal varices, caput medusa, splenomegaly. Estrogen, increased estrogen can also cause spider angiomas. Not really clear why you get these spider angiomas, but you get these like on your face, you get it on your different parts of your body, but it has to do with increased levels of estrogen. And then, of course, gynecomastia. And then when you see all these different lab tests, again, elevation of all these, right? AST, ALT, gamma GT, know your ratios, right? Greater than 1, less than 2. Reduction in albumin. What else? Increased estrogen, PT, PTT, bleeding time, right? Because you get thrombocytopenia if the spleen's too big. So here's a nice little overview of liver damage. One thing that you can also see is clay-colored stool and darkening of the urine. So darkening of the urine, you're starting to get bilirubin, so urobilinogen now, it starts getting accumulating and can be excreted in the kidney. And you're going to get a reduction of stercobilinogen. So stercobilinogen is what produces the brown color in stool. And so you're going to get clay-colored stools, so it's going to be kind of faint-looking. And then the urine, on the other hand, is going to be really dark. So those are some of the major signs and symptoms of liver disease. Any questions? All right, so last time we were closing up on Wilson's disease. Wilson's disease is effectively a disease involving copper accumulation. That's the major underlying pathophysiology on it, is an accumulation of copper. So you have a deficit, or a defect in metabolism of copper. Copper is really toxic in high amounts. If it starts depositing in different parts of your body, including your liver, including your brain, and other places, it can cause some serious damage. It can cause serious damage in the kidneys, and in terms of neurological deficits, it can actually cause some pretty serious neurological deficits as well. So here's the main idea. You have ceruloplasmin is going to be the major thing involved in Wilson's disease. If you have a deficiency of ceruloplasmin, you're going to have a greater amount of unbounded copper, and the tissues that are affected are liver, cornea, brain, and kidney. This little phenomenon that you see in the eyes looks really pretty. It's a nice little pretty ring around the eyes. That's called a Kaiser-Fleischer ring. And Kaiser-Fleischer ring in the eyes is effectively pathognomonic for Wilson's disease. So that's going to be one of the major findings you see. You'll find other things too. You'll find like neurological symptoms. Maybe the person will have tremors. Maybe they'll have other neurological deficits like unsteady gait, things like that. So there's lots of different neurological symptoms that you'd be able to see. So you might have tremors. You might have your speech affected. You might also have dystonia or disordered muscular tonicity. But then again, Kaiser-Fleischer rings, one of the major things you see on the patient's eyes. And over time, Wilson's disease results in cirrhosis. Okay, so this patient will eventually develop cirrhosis. Because it has to do with a lot of copper within the serum and reduced ceruloplasmin, the way that you treat Wilson's disease is by using a drug that can help chelate the copper out of the blood. So it's a copper chelator. One of the most commonly used drugs for this is penicillamine. Penicillamine. Easy drug to remember because copper, pennies, penicillamine. Right, so there's another drug too, but I don't remember it. But penicillamine is good enough to treat these patients for the most part. So let's close out liver by going through this whole entire chart. I think it would be a good idea for us to just do it all together. So let's go through one at a time. So with viral hepatitis or NASH, what does NASH stand for? Do you guys remember? Steatohepatitis. Good. So NASH is non-alcoholic steatohepatitis. Excellent. So jaundice, do you think there's going to be an issue with jaundice, bilirubin, and all that? You're basically going to see jaundice in all of these conditions. So pro tip, jaundice is going to be something you'll see with any of these conditions. So with NASH and viral hepatitis, you'll see that as well. What is the AST-ALT ratio? Which one is going to be more elevated? AST or is it ALT? ALT, good. So the ratio of AST to ALT is going to be less than what? Good. It's going to be less than 1. Are you going to see gamma GT in this condition, in this patient? So you're not going to see elevations in gamma GT with this patient. What about albumin levels? Is albumin going to be affected? Yes, no, maybe so. Is the liver still able to produce albumin, you think? The answer is yes. The liver can still produce albumin, even though this hepatitis, that just means there's inflammation. It's not quite cirrhosis yet. Eventually, it could turn into cirrhosis. Then you'll see albumin getting affected by that. What about your prothrombin time, the partial thromboplastin time? Are you going to see elevations in that? Is your liver, if your liver is able to make albumin, do you think it's able to make clotting factors? Yeah, it's still able to make clotting factors, right? So is your PT going to be elevated, PTT? No, it's going to be normal. Okay? So the liver is still functioning. It's just, it's got some damage. Right? That's effectively what's going on with hepatitis in general. Hepatitis means you got liver damage. It's still functioning, but it's working, but it's not like cirrhotic yet. What about alcoholic hepatitis? Jaundice? Yes, good. AST to ALT ratio. Which one is going to be higher in alcoholic hepatitis? So we've established that ALT is going to be the one that's mostly elevated in viral hepatitis and non-alcoholic steatohepatitis. What about alcoholic hepatitis? AST is the one that's going to be higher. And so what's the ratio going to be? So it's going to be greater than 2. Okay, so your AST is going to be your numerator. The denominator is going to be your ALT. Your numerator is going to be really high, so maybe like 300 or something. Maybe your ALT might be like, 80, right? 300 divided by 80, and it's going to be potentially greater than 2. Okay. What about gamma GT? Are you going to see this with alcoholic hepatitis? Yes. What about albumin? What's going on with albumin? Is this cirrhosis yet? It's not cirrhosis. Is albumin going to be affected? No. Good. What about your PTT? No, it's not going to be affected, right? Because if you can still make albumin, you're still going to be able to make your clotting factors, etc. What about cirrhosis now? Are you going to be jaundiced? Yeah, for sure. You're going to be definitely jaundiced. Now, the AST-ALT ratio is going to be a little bit different. They're both going to be elevated, right? So they're going to be greater than something, but less than something. They're going to be greater than what? Greater than 1, but less than 2. Excellent. What about gamma GT? Is that elevated? Yes, that is going to be elevated. Now, albumin. What's going to happen to albumin? Elevated? Lowered, right? Because the liver is failing and it's not able to produce albumin. So your serum albumin is going to be low. You're going to have hypoalbuminemia. What about your clotting factors? Also are going to be not produced. And so your PT and PTT is going to be elevated. Now, what happens if the spleen is involved? What's another test that you might be able to see being elevated? What's happening if you have splenomegaly with cirrhosis? What happens to your platelets? Do you guys remember? So the platelets, if you have splenomegaly, your spleen's enlarged. One of the things the spleen does is clears out the blood, sequesters old red blood cells, but you can also have deposition of platelets in the spleen. So you might see sequestering of platelets in the spleen causing thrombocytopenia. So if that happens, you're also going to see an elevation in what test? It's going to be a platelet-style bleeding. Yeah, bleeding time is going to be elevated. So BT will also be elevated if there's splenic involvement. So if you have splenomegaly, you're going to also see increased bleeding time. So good job on that. Let's do some quizzes questions, and then we will continue on with renal. So go ahead and log in. All right, I'm going to go ahead and begin. If you weren't able to log in yet, you still should be able to do so. Good. Alcoholic hepatitis, 500 divided by 100, 5, right? That's over 2. So the ratio is above 2, so that's going to be alcoholic hepatitis. So good job on that. Let's move on. Oh, wow. Okay. Hepatitis A, hepatitis E. What are those? How do you get those? Yeah, it's usually like contaminated food. That's kind of the common way to get Hep A, Hep E. Hep A is acute. It's around like 1 month or so. You'll start seeing symptoms, and generally it just resolves on its own. Hep E is pretty similar to Hep A, except only that Hep E is way worse for pregnant women. Hepatitis D is a co-infection with hepatitis B. It's either a person who currently has Hep B or has had Hep B in the past. Those are the ones that are vulnerable to hepatitis D. But the vignette talks about a 35-year-old woman. She's presenting with fatigue, loss of appetite, and jaundice lasting for weeks. She admits to IV drug use in her youth. She's been abstinent from drug use for 5 years. She's got the sclera icterus, which means that the white parts of her eyes are turning yellow. She's got hepatomegaly, tenderness in the right upper quadrant. AST and ALT levels are elevated. IV drug use. Hepatitis B is sort of a sexually transmitted disease, sort of. It can also be transmitted through infected needles as well. Hepatitis C, is that the most common blood-borne illness in the United States? Is it? Hepatitis C is the most common blood-borne illness in the United States. Back in the day, you would especially see people getting Hep C from tattoos. Nowadays, tattoo artists tend to be a little bit more mindful in how they actually clean their equipment. But back in the day, like the 1960s, 1970s, etc., they weren't. And so a lot of people who had tattoos, 40 years ago, 50 years ago, a lot of those folks sometimes develop Hep C. And Hep C is a chronic illness, right? So eventually it turns chronic. Hep B, 20% of cases will eventually turn chronic. So this lady could either have hepatitis B or hepatitis C. That's a long story short with this. So I want you to associate Hep B and Hep C with sexual transmission for B, but both of them can also be transmitted through IV drug use and contaminated needles. Okay? Are we clear on that? All right, awesome. And by the way, with the last patient, I forgot to mention this. So AST and ALT is going to be elevated in the last patient who had Hep B or Hep C. What is the ratio for ALT, AST? Yeah, so ratio is going to be less than 1, right? Because cirrhosis would be greater than 1, less than 2. So you're right. So ratio is going to be less than 1. That's because the ALT is the one that's going to be more elevated. Now with this patient, this is non-alcoholic steatohepatitis, and BMI of 35, that's pretty high. Once you get to BMI of 30, 30 is sort of the cutoff for being obese. Between 25 and 30 is going to be considered overweight. Above 30 is considered obese. Once you get to over 40, that's considered morbidly obese. That means that you're in dangerous territory. 35 BMI, that's going to increase your risk of developing fatty liver disease, right? So this is non-alcoholic steatohepatitis. So, did you have a question? Oh, whoops. Is it about that? Oh, sorry. All right, so what was your question?
Oh, I just have a question about hepatitis.
Yes.
So I know that D is a co-infection of B.
Yes.
So if you always have D, you have B, right?
If you have D, you either currently have hepatitis B or you've had hepatitis B in the past. Yeah, so it's a co-infection. Ooh. Yeah, okay. So both of these are elevated. AST and ALT are both elevated, but they're elevated in a way where it's very similar, right? They're going to be elevated very similar. So let's do the math on this. Let me make sure I got the numbers correct on this. Just want to make sure. It's 1.2? Good, thank you for doing that. So 1.2, that means it's greater than 1, but it's less than 2. Okay? So this would be cirrhosis. If this was alcoholic hepatitis, the ratio would be greater than 2. Your AST level would be markedly elevated. So if your AST level was 375 and your ALT was, 50 or something like that, then that would be considered more alcoholic hepatitis. Are we good on that? I want to make sure we're good on that because the majority of you guys got that one wrong. So are we good with the ratios? So they're very similar. If you see the elevation of AST and ALT, if the numbers are both elevated in the hundreds, but they're both elevated almost similar, right, then you're thinking that this person probably has cirrhosis. Yes?
I thought you divided like 375 over 450.
So AST 450 over 375. No, yeah, you know what? I should probably switch these numbers around because let me see here. What's AST? Yeah, that would be 375 divided by 450. Yeah, I need to change the numbers on this, but the concept's still similar, right? This concept, the fact that the numbers are close together, right, in their elevation, the ratio is under 1. So I need to fix these numbers. My bad. Let me go ahead and do that right now. So, sorry about that. All right. Now, if you go back into it, the numbers should be correct. Yes?
On exam, would you switch it on this? Or would you try to keep it consistent?
I would, okay, so on an exam, if you were to see, it would be really obvious, right? This is, if you switch those numbers back and right, if you had it, so the ALT was 375 and AST was 450, it would be pretty obvious that the ratio would be very close, right? But it would be very obvious that if it's alcoholic hepatitis, then you're going to see a marked increase in AST. If it's NASH or viral hepatitis, you're going to see a marked increase in ALT. But if the numbers are both similar and they're both elevated, you're thinking cirrhosis. Okay, so that would be it would be very obvious. Of course, you're not going to use calculators on the exam, so it will be easy math. This one's a softball question. I'm sure most of you got this one correct. The biggest giveaway, well, they got the neurological symptoms, and you got the Kaiser-Fleischer rings. So yeah, this is Wilson's disease. Ceruloplasmin, excess amounts of copper, or you could treat it with a copper chelator. All right, good. Yeah, so if you have choledocholithiasis, you're going to have liver involvement, right? So you're going to see jaundice, bilirubin's going to be elevated, vitamin K is going to be affected, so that will increase your prothrombin time. You're not going to get fever and leukocytosis, right? You get that in like cholecystitis, you'll get that in cholangitis, right? So you'll see fever and leukocytosis in those conditions. So good. Let's continue on. All right, so this patient is obese, right? She's a female, she's in her 40s, so this falls in line with that really, really rude but way of like remembering this. Fat, female, 40, all of that. Right upper quadrant pain, radiates to the back. So this is really severe issue with the gallbladder. And then Murphy sign is positive. So you got a little bit of cholecystitis in there as well. But then the fact that the liver involvement, you got liver involvement. So this is, what is this specifically called? This is a stone that is blocking the common bile duct. What is the term for that condition? So she's probably got a gallstone in her common bile duct. So that's choledocholithiasis. So some of you put down ERCP, and that's also correct. That could have been correct as well. For this patient, because they have gallstones, though, you also want to remove their gallbladder. So you want to do a laparoscopic cholecystectomy on this. ERCP could also be done to dislodge the gallstone in the common bile duct. So I'm going to fix this question. So I'm going to do select all that apply, and the correct answers will be C and D for this patient. Reducing fatty foods and proper weight management, that's like a long-term goal. And if you remove the person's gallbladder, they're going to have to do that eventually, but that's not going to be the original, like the upfront treatment, right? You're not going to be like, oh, cool, just go home, diet and lifestyle modification, you'll be fine. It's like, no, it's actually pretty serious. This person's getting like jaundice, they're getting liver damage, so you want to do an emergency laparoscopic cholecystectomy, and you want to, if there's a gallstone in the bile duct, you could do ERCP as well. So yeah, you wouldn't just prescribe weight management for this patient. This would be after the fact. And once you remove the gallbladder, you don't have the gallbladder to store bile anymore. So you're going to get very little bile entering into the duodenum after a cholecystectomy. So they are going to have a low-fat diet moving forward. What's this triad called? You got right upper quadrant pain, you got jaundice, you got fever. There's a term for it. Starts with a C. Charcot's triad. Charcot's triad. So this is Charcot's triad. So when you have jaundice, right upper quadrant pain, fever, that's Charcot's triad. So make sure you're familiar with that term, Charcot's triad. All right, let's read through this one. John's a 50-year-old man presenting to the emergency department with severe upper abdominal pain radiating to his back. He's got nausea and vomiting. He's got a history of gallstones, so cholelithiasis. He reports episodes of jaundice. On examination, John exhibited tenderness in the right upper abdomen, and laboratory tests show elevated amylase and lipase, confirming the diagnosis of pancreatitis. So this is where you have, this person does have cholelithiasis, but more importantly, this is a really severe case of cholelithiasis. So it's not only blocking the common bile duct, but it's also really close to the ampular levator. Remember, the ampular levator is like that's where you have the merging of the pancreatic duct and the common bile duct. And so if it's affecting the pancreas, this is really serious. So this can cause pancreatitis, effectively. That's what this guy's getting with the elevation of amylase and lipase. So this is way beyond cholecystitis. Cholecystitis would only be the gallbladder. This is beyond cholelithiasis. This is cholelithiasis. It is blocking the ducts. Are we good on that? Yeah? Okay. All right, last one. So pancreatitis, amylase, and lipase are going to be like the hallmarks of pancreatitis. And if it's associated with alcohol, because that's one of the major causes of pancreatitis is alcoholism, then you'd also see liver enzymes being elevated as well. So you'd see elevation of AST, ALT. So, yes?
Do you also see protease or no?
But that's not really something that's measured when you're measuring pancreatitis. I imagine that you would see elevations in protease. Let me just look that up real quick. Yeah, the major things that you're going to be tracking are lipase and amylase. You're not really following protease. I imagine it would be elevated too, but it's not something that's clinically, like, you don't really follow protease levels. Amylase and lipase would suffice. Cool. All right. You guys have some reviewing to do when it comes to like your gallbladder disorders. So make sure you go over those questions again. Make sure you go over the slides again for next week's exam. So rock and roll. Any questions before we move on to urology? No? Let's do it.